Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features expert answers to clinician questions on current and emerging biomarkers relevant to the use of immune checkpoint inhibitor-based therapies for patients with advanced non-small cell lung cancer. This episode is part of a larger educational program titled New and Evolving Therapeutic Targets in Lung Cancer: Expert Guidance in Incorporating Biomarker Testing to Deliver Precision Therapy. During this podcast, Dr. Edward Kim from the Levine Cancer Institute in Charlotte and Dr. Leora Horn from the Vanderbilt Ingram Cancer Center in Nashville will answer questions asked by the audience during a live webinar on such important topics as emerging biomarkers indicating a lack of response to checkpoint inhibitors, identifying patients who would benefit from chemotherapy combined with either single-agent or dual immune checkpoint inhibitors, and selecting therapy for disease without actionable driver mutations and with different levels of PD-L1 expression. For more information on Dr. Kim and Dr. Horn, along with a link to the complete program, including a downloadable slide set and a downloadable PDF of key points from this podcast, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Welcome, everybody. Really great to do this together with Dr. Horn. Okay, so we do have some questions. So first one, I'm going to sort of just answer what's the approach to a non-small cell lung cancer patient whose tumor is PD-L1 1 to 49%. And I think on the higher side, you like to give the single agent, but in the middle, I think I'm a 189 person. I assume you're probably in that area as well.
Yeah, it's a pretty easy regimen to give. So yeah, 100% agree with you. So Keynote 189 was one of the positive trials. This was a trial looking at chemotherapy with platinum pemetrexed and pembrolizumab followed for 4 cycles, followed by maintenance pemetrexed and pembrolizumab, or platinum and pemetrexed chemotherapy, again, excluding patients who are EGFR and ALK positive. We saw patients were enrolled regardless of their PD-L1 expression. We saw a higher response rate with chemotherapy and checkpoint inhibitor, around 50% compared to around 20% for chemotherapy alone. Progression-free survival of 4.9 months for patients receiving chemotherapy. Some folks arguing that the control arm underperformed in this study, compared to 8.8 months with the combination, and a median overall survival that had not been reached for patients receiving pembrolizumab and platinum pemetrexed therapy, compared to 11.3 months overall survival in the control arm.
Yeah. Okay, one question. Patient, driver mutation negative, PD-L1 80%, NGS shows STK11 and KEAP mutation. What's your recommended first line? IO alone versus IO chemo versus IO doublet?
I haven't done IO doublets, although there is some suggestion that maybe you can rescue those patients with ipilimumab when you add it to nivolumab. I might think about the 9LA regimen in this patient with carbopemetrexed, nivo, ipi. I wouldn't give IO alone. I have some patients, unfortunately, in retrospect, as this data was emerging before I even knew about it, who did not do well with chemo or IO alone. So I would go for a combination therapy, and I would probably think about the 9LA regimen. Now, this was a study that looked at patients with chemotherapy for 2 cycles with nivolumab and ipilimumab, followed by maintenance nivolumab and ipilimumab compared to chemotherapy. Now, what the purpose of the study is for many of the survival curves, when we see CheckMate inhibitor therapy alone, we see this rapid progression in a cohort of patients. And the question was, what if you give 2 cycles of chemotherapy with the checkpoint inhibitor up front? Could you potentially not have that rapid progression? And we can see in the survival curves that maybe we can. This study demonstrated a significant improvement in overall survival, 15.6 months, with nivolumab, ipilimumab, and chemotherapy, compared to 10.9 months for patients receiving chemotherapy alone, and a hazard ratio of 0.66.
Yeah, I think there are going to be some niches agree with that regimen. It showed some intriguing data. Just sort of along the same line, somebody was asking about TMB. they were asking about controversial cutoffs. I think there's been a lot of talk about the controversial cutoffs, but we still don't find a very good role for TMB for non-small cell lung cancer. So here's a question. Would you test for STK11 and keep one prior to deciding on PD-L1 therapy in first line?
No, well, we're lucky. It comes as part of a, most NGS panels will actually give you that information. So it's there. I don't know that I would specifically look to test it and exclude a patient because we just don't know enough yet. If a patient's got a KRAS mutation, they're more likely to co-express STK11. So you might have it in the back of your mind if they don't respond to it, because there actually is a trial open now through LungMap looking specifically for patients who have STK11 with a targeted agent. So I think about it for clinical trials, but outside of a clinical trial, again, not ready for prime time.
Yeah, no, I think that's a very, very, very reasonable and rational approach there. And another question mentioned the NFE2L2 mutated non-small cell lung cancer patients have seen similar outcomes as KEAP1 in very specific question. I don't know that data. So
I think that was also coming out of similar data that Dr. Scalito was looking at. There was interesting data that came out of Dr. Scalito at MD Anderson looking at STK11 and LKB1 as potential predictors of lack of response to benefit or checkpoint inhibitor therapy. He looked at this data specifically in patients enrolled in Keynote 189, and he looked at patients. It was a retrospective study for patients who enrolled in the trial. He looked at those patients who had an STK11 mutation and compared them to patients who were STK11 wild type. What he found is that patients who had an STK11 or KEAP1 had appeared to derive less benefit when they were treated with chemotherapy and a checkpoint inhibitor, both in terms of progression-free survival as well as overall survival. Again, I do wonder if eventually we're gonna, we don't have a biomarker. Everyone keeps talking about the biomarker. It's lacking because everyone's looking at it in silos, not across tumor types. And until we look across tumor types, this is a drug that transcends tumor types, so it's not specific to lung. So, I do wonder if eventually we'll emerge with a lack of benefits, similar to how we knew if you're KRAS positive, don't give an EGFR inhibitor. If you have XYZ, don't give a checkpoint inhibitor. But we're not there yet, I think, to exclude patients from therapy.
Yeah, a lot of sort of scientific interest, but pragmatism is not taken over yet. And one question came in about if you detect a mutation on NGS, but you have a PD-L1 greater than 50%, what would you do? And I'll just chime in, you want to treat the druggable mutation. That's generally the route we go, and then treating the PD-L1 status per se. One question from Peru, so it's nice to have an international audience, is after progression with carbo-pembro, so 189, what's the best standard of care? So what do you like to do in those patients, Leora?
Yeah, outside of a clinical trial and outside of, I feel like with checkpoint inhibitors, we've also gone to this kind of like oligo progression, like where did they progress? Is it one area? Can you radiate it and continue them on their therapy, which I do sometimes. But that aside, assuming there's a lot of progression, unfortunately, we're back to docetaxel and with or without ramucirumab. I don't know if ramucirumab's available in Peru, but that's sort of my go-to regimen. How about you, Ed?
Yeah, that's exactly what we do. We'll try to sort of retest markers, but docetaxel ram is what we use in that situation as well. It's kind of become sort of our default, I think, there. One question that came up was, will there be a biomarker that will be better to replace PD-L1? I feel like we've been talking about that a lot at a lot of lung specialty meetings, and everyone talks how badly PD-L1 was, but it's sticking around. It's a survivor right now.
Yeah, hopefully we'll get one soon.
Yes. Yeah, I agree. I think it's more, a lot of the studies have used it, and so we're finding some differences, but again, hopefully we'll have a better one. And then one is a patient who had a mixed response to first-line pembro, resolution of most of the lesions, however, a few new small lung nodules, not amenable to local treatment. Would you add chemo and continue pembro, or would you go off the pembro? So how does that type of progression dictate how you're going to treat the patient?
So I think it depends on the size of the nodules. I had a patient who was responding really well, and about 18 months, tiny little lung nodules showed up, and lo and behold, we biopsied them and they were histo. So I think that you need to prove that it's because they were PET avid, they were just over a centimeter. I think you need to prove that it's true progression. And if if you can't prove it, I think it's worth continuing the pembro and sort of waiting a little bit more, scan about 3 months later, and wait till you can biopsy. You'll get definitive evidence of progression.
Yeah, I think that's a great answer. We always like to jump whenever we hear a radiologist say something, but truth of the matter is you look at what's the imminent danger, and if you're getting a response in a lot of the disease and the other stuff is non-threatening, it's okay to watch it grow a little bit as long as you're following the patient closely. So and let it declare whether it's really truly disease. And then we'll go with this question. So no driver mutations, PD-L1 less than 1%, and they can receive anything with any type of treatment. What will you treat that patient with?
I think it's kind of like you get comfortable with something. So a non-squamous patient, I'm going to give carbo pemetrexed pembro. A squamous patient, I'm going to give carbo nab-paclitaxel pembro. I know a lot of people are excited about the 9LA regimen. I'd like to see 3-5-year survival that is so much better before I go to a more expensive, potentially more toxic regimen. So that's sort of my go-to. How about you?
Yeah, I'm intrigued by 9LA, but I agree exactly with you. The 189 works very well. It's very predictable side effects. In fact, there are very few. And IPI kind of scares me a little bit still. It shouldn't. The melanoma doctors laugh at us when they see the dose of IPI that we're using. But I think it's until something's proven better, and we have some data around it, I'm not ready to just sort of switch the same way. And then one question was around stopping IO therapy due to side effects and then rechallenging later after corticosteroids. I think you got to weigh that by how bad the side effect was. Things can be very subtle, and we don't know what the optimal length of duration of treatment of IO is. And so, just because you can treat with steroids, get somebody back down to a less than grade 1 toxicity, they're still at risk. And so I think that's really a consideration you have to take on a case-by-case basis. Leora, any thoughts there?
Yeah, no, I agree. I actually had a patient who had grade 3 pneumonitis on the initial nivolumab trials, and then he maintained his response for a while, but when he progressed a couple of years later and nivolumab was approved, he talked me into a rechallenge and he got grade 3 pneumonitis again and he almost died. So it depends on the severity, that you don't want the treatment to be worse than the disease.
Yeah, I totally agree. So, okay, well, we're going to close this part out.
Thank you very much, Dr. Kim and Dr. Horn, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, New and Evolving Therapeutic Targets in Lung Cancer, Expert Guidance in Incorporating Biomarker Testing to Deliver Precision Therapy, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. Thank you for listening.